My name is Tashima Lambert Giles. I am an OBGYN. I currently practice at VCU in Richmond, Virginia. Prior to that, I practiced in Washington, D.C. at a federally qualified health center. I am from St. Croix, U.S. Virgin Islands. I grew up in St. Croix. I came to the States when I was 17 to attend college. And I actually came to Virginia. I came to UVA for undergrad, and then since there, kind of moved around for medical school in Philadelphia, and then did my training at Duke in North Carolina, and then went to Washington, D.C. for my first job out of training, and ultimately moved back to Virginia in hopes of making a big impact in this community. One had of medicine and being a doctor, I was really surprised and heartbroken for a little while, until I joined National Health Service Corps. And then I realized that there really is a coalition of doctors out there that do feel the same way that I feel, that do want to care for populations and for communities that are the most vulnerable. And it really reminded me that there's different reasons why everybody has a career. And medicine is no different than that. It is a career, and some people go into it for some reasons and others for other reasons. I would explain health equity as seeing people for who they are and meeting them where they are. I think we have so many definitions of health equity being the thing that is giving others what they don't need or giving others what they need in order to accomplish something. But for me, I see health equity as seeing my patient for exactly who they are, what they're bringing to the table, and seeing them for what they need in order to accomplish the goals that they have. I think it's important because we all talk about patient-centered care. We talk about what is the best thing for our patients and the best outcomes for our patient. And sometimes those outcomes might not look the way that we might expect it to look. And patients might not actually want or desire the same things that we want or desire for them. And I think that's important to center them and their needs, and their ability to accomplish those needs in our care for them so that they are getting the care that not only that they want, but that they are getting the care that they deserve and that they need. When you become a doctor, you have spent so many years in training, in school, and not a lot of that training integrates how people's outside world actually affects the care that you're offering or how they can accept that care. So I think it's important that we recognize that health equity means involving legislation, community, groups that can offer things that we can't offer from a medicine standpoint so that we can optimize all of our patients' outcomes. Black maternal health is looking at the actual health outcomes, and the disparities that we see in the prenatal, pregnancy, and postnatal phase of people that identify as Black in this country. I would definitely say Black maternal health was not something on my radar. Um, as a medical student, it was not on my radar as a resident. And as I was completing residency, I do think that I became exposed to Black maternal health as a virtue of legislation, as a virtue of it being something that started to become more mainstream in our popular culture, by hearing the stories and the voices of outcomes that has been occurring across the country. But then in my first job, as I mentioned, I was in a National Service Corps and I provided care in Washington, D.C. My patient population was over 90% African American, um, or Black, how they might identify. And I worked in the region east of the river. That region was considered one of a high health professional shortage areas. And in that moment, when I was caring for women that was almost an entirely Black population, I recognized the stark differences in the care that they have access to in the outcomes that they were having in comparison to other women that I had recognized where I trained, perhaps. And I think in that is when Black maternal health became something that was important to me, that was recognizable to me. And then I continue to see perpetuate in our media. Our last administration did a great job in us naming it and acknowledging it as a problem. And I think because of that, we have gained the benefit of seeing Black maternal health become something that more than just doctors are aware of and more than just community workers and doulas are aware of. And we are seeing it on CNN and Fox News. And we are seeing these stories of moms that have preventable outcomes. And I think that exposure is something that is important, and that exposure is something that has fueled a lot of research and a lot of good outcomes that we've been able to find ways to combat this epidemic. If you are birthed in this country, you should be looking for someone that sees you. You should be looking for someone that acknowledges your story, that acknowledges every part of who you are and not just your medical chart. I think you should be looking for a provider that wants to engage all of the people that you want to engage in your care, because we recognize that we are seeing patients for 15, 20-minute visits, and the rest of their life, they have partners, they have family, they have moms, sisters, they have church members, they have so many other people that's their coalition. And you should be looking for a provider that wants to engage all of the people that you hope to engage and that is looking to hear what you want from your outcome and how we can best work together to accomplish that. I think a health system that supports all birth-in patients look like one that is accessible, one that is willing to see all patients, regardless of their ability to pay, regardless of their education level, regardless of their um, religion or language preferences. But that organization also looks like helping to bridge the gap of the resources that those patients with limited resources might need. It's one that's willing to meet patients in communities that they might not be able to access care. It's one that might help them with transportation to get to certain locations if that's what they need. It's one that would look like having interpreters to talk to patients in their native languages so that we can make sure that that communication is as clear for one patient as it is for the other. It's one that's willing to take the time if it means additional appointments, if it means additional partners in care, one that actually links that patient to the resources that they need. I think one of the biggest wins that we've had been the expansion of Medicaid. That has really helped us to focus not just on pregnancy as the event, but recognize that the health of a pregnancy and the health and the outcome of that pregnancy is so importantly linked to what happens before pregnancy and what happens after it. And the expansion of Medicaid has allowed us to offer patients the care that they might need for preconception, the care that they might need to optimize their health and their needs before becoming pregnant, and then to actually optimize that post delivery after they've had different outcomes in that pregnancy. For our patients with basic things like diabetes, making sure that they actually have providers that can continue that care when they're no longer pregnant. For our patients that might have developed things like preeclampsia, we recognize that their cardiovascular health is now at a higher risk than the baseline population. So being able to actually have them see primary care providers post delivery because they still have coverage. For patients that might feel pregnancy is no longer safe for them and it's not something that they want, being able to offer contraception and sterilization without the cost to them or without the worry that they can't afford contraception and sterilization if that's something that they desire has been a really big win for the expansion of Medicaid. And I do fear that not having that and not having a continuum access to care will only make patients not optimize for the best outcomes. And for patients that already did not have the best outcomes, not helping them and their health outside of pregnancy because they don't have providers that can care for them. I could solve maternal health in 3 ways. I think I would invest in our communities, and that would look like having additional resources in our communities, like paid time off, like affordable childcare, um, like safe communities, transportation and infrastructure to get to places. I think when we talk about invest in our community, I mean talking about the legislation that is necessary in order to make the drivers, their social drivers, be a moot factor in their health. So I think that that's one thing I would do. Work on legislation to help our communities be a safer and more accessible place for care. I think I would invest in providers that want to be and stay in communities that need them. I think one of the hardest things in becoming a physician is the cost that people assume by becoming doctors. And that cost sometimes is not outweighed if you are attempting to give care in practices that need it, in communities that need it, and people feel forced into either practicing in different locations or forced into doing specialties that they might not be as passionate about in order to offset the cost that it actually meant to become a doctor. So I would invest in communities. I would invest in medical education and the cost of medical education. And I think I would do a better job at making sure that we are expanding the ancillary services that come with pregnancy. Things like lactation, things like mental health. Those services are the services that patients need in order to thrive after having a baby. And I think that we don't always have the resources or the places to send those people for additional help in those things that me as their OBGYN might not be the best provider to assist with. For colleagues, I would always encourage them to recognize that being an advocate doesn't have to look one way. Being an advocate might mean that you are honing in on one area that you see your patients might need additional assistance in and making sure that those patients are actually getting that assistance that they need. Being an advocate means seeing your patients and really centering your patients at the level that all of the choices and the decisions that you guys are making, you're making them together and that you're making them with a full understanding that they recognize it is truly an informed decision. And I think it can be that easy to be an advocate. And it doesn't have to look the way that we think social media might make advocacy look. It really just means seeing your patients and truly offering them patient-centered care. And if you can't offer them that care, helping them to link to resources that can.